You may have heard the phrase that anatomy is destiny, but maybe you didn't think of it in terms of repetitive strain injury. But it can be particularly true with RSI. Every body is different, which is one of the reasons why people can't understand why some people are more prone to injury and others aren't. So we're going to get some fascinating input about this and why this happens from our chief medical advisor, Dr. Robert Markison. We've had some really interesting conversations in the past about anatomical variations. And I'd like you to tell people some of the things you've noticed having been a surgeon and actually getting in there and seeing all these differences between bodies.
Well, yeah, a little background without arrogance or false sense of arrival. But when I ran hand surgery at SF General from 1981 to 89, by agreement with the then coroner Boyd Stevens, a dear friend, who would come in the OR when we had a fatality, and I do all my own postmortem exams with him when we had a death. But then subsequently had all the unclaimed dead under my wing. I'd keep them for 5 or 6 weeks, dissect them from head to toes, then pay cremation. That sounds macabre. It worked very well because I was dissecting for colleagues, for residents, medical students, hand therapists, and artists who wanted to know more about form, function, fit, failure avoidance, and anatomical variation. Whether you're up in the skull with the brain or whether you're looking at all the nerves coming out of the foramina, the windows, and ramifying to become brachial plexus, go under the collarbone, become peripheral nerves, all of this gorgeous stuff, but realizing that no two people, even side to side, within a person are put together the same way. And then you realize, for example, there are 38 primary anatomical variations of the brachial plexus of nerves, roots, trunks, cords, plexus, peripheral nerves. And between that, there's infinity. And so if you have a taste for mystery and maybe infinity, then you look, for example, at the anatomical variations of the brachial plexus. I mean, that's a lot of stuff. I mean, a really smart medical student would memorize one pattern, but gee, there's the spine there and there's all the branches. Could you imagine just staying up all night and reading about it? Well, I think it's good reading. I think it's good to know as much as you can. We had gunshot wounds, machete wounds, all kinds of wounds to the brachial plexus. And we had to figure out how to put atypical spaghetti together under a microscope at night without books open. And so that's at nerve supply of the upper limb, and that's outgoing, incoming, outgoing motor, incoming sensory. And then you get out to peripheral nerves and you have an amazing variety of crossover. And so that can really befuddle the observer because you've got all these potential crossovers of median meets ulnar in the forearm, surprisingly common. And so you could have numbness and tingling in different parts of the hand based on what's called Martin Gruber or other types of anastomoses, hookups, connections, crosstalk, so that could make a very difficult diagnosis. So somewhere between crossovers at brachial plexus, crossovers forearm, crossovers within the hand, you could make diagnostic errors that could lead to wrong or incomplete treatment. And so that's just nerve. Sorry.
If I'm understanding you correctly, if someone's wired differently, they might have numbness or tingling in an unexpected digit?
Absolutely. I mean, classic thoracic outlet syndrome, C7, C8, T1, would be numbness and tingling in the ulnar nerve territory. But if you're one of the many variations or something in between of the brachial plexus, you could have total hand numbness and tingling that is still coming from brachial plexus. And the traverse of these nerve roots and trunks through a morass of fibromuscular tissue at the neck and behind the collarbone out to the upper limb, including armpit, can really determine how somebody's going to present. So they can present with, quote, I've got carpal tunnel, then they get scheduled for surgery and it doesn't help because they don't have carpal tunnel, but they had an anatomically varied brachial plexus as the symptom generator. Then you kind of wasted time, tissue, and made trouble.
At one point you were talking about I think it was a long ulna that would, if you were ulnar deviating, it would sort of create problems trying to reach cap locks or return or something.
Right. As you're perking along in the womb, you can have bone discrepancies in length. So here's radius,
Mhm.
here's ulna. If you have a long ulna, you're at risk of impingement or abutment syndrome, where this butts up against the carpal bones, that complex of 8 bones. And then there you are, you're hammering it with caps, caps lock, shift, tab, option, enter, control, return, escape. And if you're a computer programmer, you've done all these perimeter key macros to try and get your code written. And it could be trouble. And so for a lot of these patients, and I don't know if you're into this, but I've got, nice little sets of pedals, and this is 3 little pedals, 35 bucks, Amazon.com, and I've got 2 of them. So I don't have to be Johann Sebastian Bach on his organ in Leipzig to work some pedals and get some stuff done without troubling my upper limbs.
Have the same setup I use.
Right.
It's really funny because if I'm on someone else's computer, I'm punching the floor to enter something and realizing, oh, there's no switch under there to make the key active. It's funny.
Exactly.
One time.
And so anyways, so we talked about nerve supply variations. There's variations in blood supply, including a reactive circulation where you have Raynaud's, which is suddenly cold hands that stay cold. So you don't, if for example, you were monitoring your own little oxygen saturation with a digital oximeter, then you'd know, oh my goodness, I'm tightened up, I'm inadequately hydrated, I'm cold exposed at home. I should be wearing fingerless gloves, something to get oxygen to moving parts, because I'm wired in such a way that I've got chronically cold hands, and cold hands are not fit to do repetitive work. So you want to be aware of vascular differences in the upper limbs. And I mean, it's as simple as making a fist and doing timed Allen testing. So you open the hand, you fill it from the radial artery. It should be filling within 2.5 to 3 seconds. The British Journal of Hand Surgery, 1980, 500 normal hands, they were filling in an average of 2.2 seconds from radial artery. Now let's block both arteries, fill from ulnar. And they should fill symmetrically, but you'd be surprised at how many hands are non-symmetrical. And so if you've got a slow filling hand, you have to realize that maybe hydration, maybe the way you're wired, could be aging related, vascular occlusive disease, small vessel disease, and diabetic hands, and so on. So you have to be very aware of rich inflow arterial supply and equally rich outflow vascular supply. So for example, the woman who's had a significant node dissection with mastectomy or lumpectomy may have lymphedema, so may have delayed outflow through the lymphatic system and maybe some occlusion of venous outflow. So now your environment, your ecology of the hand is quite different. You may have some inflow, but slow outflow. So you've got a kind of a waste dump out there that's cold, and you really want a warm, richly washed river of inflow and outflow. So the homeostasis and ecology of the hand as you're trying to do repetitive work matters. And so that's the vessel side of things. We talked about bone differences. There are bone differences that can occur in the thumb, limiting range of motion. There's hyperextensibility that may be a compensation for aging or other causes related arthritis. You may have generalized diabetic stiffness of the hand called diabetic chiropathy. And so you really have to think on the vascular side, inflow and outflow potential. And then when you've got tendons, and you and I met, and the real test was, and maybe your viewers would like to do it, you hold your index, middle, and ring finger out straight, try and touch your palm with the little finger. I have a congenitally absent superficial flexor of my little finger. I'm not crying about it because I spent a lifetime working around it. Now I get the deep flexor engaged that way with my ring. 5 to 8% of hands will have an absent thing like this, and 37% of hands are congenitally linked ring to little. Now when I go like that, I'm a happy trio. I mean, that's the way the hand is designed. It was never designed to do independent motion. People may be lucky and maybe a concert violinist or pianist, but not everybody's equally lucky. And yet, I'm looking for symmetry in all the wrong places, because here's my left hand, bam. And when you and I met in 1992, you showed me a phenomenal independence of the little finger. making me suddenly aware that you're probably a little more evolved than I am. Anyway, here, so here it is, okay? Fantastic. Ooh, wonderful. Not so good. So I'm not fated to try and exploit interdependence of little finger away from ring and middle fingers. And so I've designed my world of work and play around congenital linkage in that way. And then when we go on further and decide that, okay, let's study this, and let's study it on the top side of the hand. Let's study it at the extensor surface and look at cross connections so that you're not necessarily a mouse fiend if you've got cross connection between thumb, index, middle, connexus intertendinea, descriptive Greek with little Latin, to say that, oh, this is a fisherman's net, the straighteners of the fingers thrown over the hand with great variation. And thumb index linkage is common. And so you can have trouble either at a tendon level or deeper at the muscle level, the thumb index web muscle level. Plus you can have all kinds of extra muscles going into the hand. So musculotendinous anatomy and its variations can be very determining. So what do we talk about? We talk about nerves, bones, joints, muscles, tendons, all of which can be anatomically varied and require a little put on your thinking cap as an examiner.
There's one more instance that I've experienced with, you know, very tall man with very long upper arm bone. He cannot be comfortable ever seated at a computer because his elbows are sort of reaching down toward his hips. So he's going to be malpositioned no matter what he does unless he's standing. And I remember I got yelled at because I suggested for this gentleman a sit-stand workstation. We can't do that. Then we'd have to do that for everybody. I mean, this is sort of a corporate line that you get very often when you're trying to help people in large business situations. Whereas if they're on their own with a private home office, then you can really go to town and give them exactly what they need. But I looked at this guy and I'm thinking, he's a sitting duck for discomfort and worse possibly because of the shape of his bone, the length of his bone.
Absolutely, and the end of the spectrum, since I treat what you might call little people with various dwarfism and so on, and I've got some very, very tiny adult patients who could never reach all the keys in a QWERTY keyboard. And if they speak good English as first or second language, they're all onto voice recognition software to good effect. And so that combined with foot pedals, a sit-stand workstation, properly scaled child-sized keyboard for someone with dwarfism, they do very, very well, but they're certainly not going to do well with off-the-shelf generic input objects.
Yes, and one of the things I think is so important is that this is an individual situation.
Well, sure, one size will never fit all. That's why we got shoes, and you might have a wide shoe on the left and a narrow or medium on the right. And so you have disparate limb lengths, obviously upper and lower limbs, and disparate volumetric displacement of your body parts. And it's been shown in recent hand surgery literature that your actual volumetric displacement, a la Archimedes, and put it in a tub, 4.5% variation. So when you wake up, your displacement of the forearm out to fingertips is 4.5% greater at 8 a.m. than it will be at 4 p.m. And so you've got very dynamic shifts happening, and so you have to respect even the circadian clock of how you're put together.
This has been so interesting. So interesting. Thank you so much for sharing all of this with us.
Right, I say study anatomical variation, as the French say, vive la différence.
Yes, if we need to also respect the difference, I think, and show that by designing tools that are really designed for the human body instead of, I always think of egg crates, things that are so uniform that they will fit into a box at the grocery store. I think of that very often when I'm looking at the incorrect illustrations of how to set up your workstation, because we are not squares.
No, we're not. And you look at the advent of computing in the early 1980s, including Apple and IBM and all the other makers. And then you look at computers today, they look about the same. So we have a complete cognitive failure, and worse yet, a failure to design around human form, function, and fit, and a failure avoidance. And so the great designers in the vaunted halls of industry have not paid their dues in understanding real raw anatomy and its variations.
Well, thank you for shedding light on this really important topic, Dr. Markison. Thank you for coming on the show. Thanks everybody for watching. And remember, if you have a question, you can fill in the comment box at the Ask DQ channel, and we'll see if we can get it answered for you. Thank you.
Thanks.